Hi, my name is Maziak. I'm with the Erie St. Clair LHIN. I'm a health system design manager and the mental health and addiction lead. Essentially, the mental health and addiction lead role in Erie St. Clair LHIN focuses on working with all of our community and hospital providers in order to provide better care for our clients. We focus in on wait times, so we want to improve access. We want to address the number of repeat ED, mental health and addiction visits, and we also want to address the need for greater coordination amongst our providers in order to ensure that our clients don't have to tell their story more than once. In 2012, the Erie St. Clair LHIN conducted a mental health strategic plan. This plan focused strictly on the mental health providers because essentially the providers had not had an opportunity to have the lens shown on their services and their struggles in the last 10 to 15 years. Within the strategic plan, we identified 67 strategic directions, and then they were stratified into a multi-year roadmap. That roadmap required further work by our providers, and that occurred in June of 2012. From that, our Erie St. Clair LHIN board approved the roadmap and 5 promising practices. The promising practices went forward in the fall of this year. The 5 promising practices to elevate mental health services in Erie St. Clair are the Transitional Stability Center in Windsor, Essex, the Rapid Assessment Intervention Treatment Team for Chatham-Kent and Sarnia-Lambton, a LHIN-wide psychiatrist lead, Dr. Tamison Dewey, and our Fast Access to Community Expert, or FACE for short. In addition, we've also invested in suicide coordination and prevention as a one-time initiative in order to ensure that we build upon the current capacity and we also look at a model that will be sustainable over time. The Transitional Stability Center was also referred to as the inner city model, and it really focuses in on having a better means of servicing people who repeatedly go to the emergency department for mental health conditions but are not admitted. And so frequently we've learned that this population group are actually attached to numerous different providers, but they're not engaged. Many of them are at risk for homelessness or are living in subsidized housing and at risk. So we know that if there is a way that we could further engage this population and to work with them to achieve their goals, be it psychosocial or their medical stability, that we would be able to then take them to the next level. So the Transitional Stability Center is an actual physical place where we hope to divert emergency department visits to go to this place, and that they would then be embraced by a team of social workers, psychiatrists, nurses, and caseworkers. So we would then be looking at them from a holistic lens. They may be asked to stay 2 to 3 weeks, maybe longer. It's a completely voluntary program. Afterward, these folks will be followed by an outreach team, likely for 2 years. We know that people are complex and each individual will have their own unique set of needs. Many of them are unmet, which is why they repeatedly cycle through the emerge. So we're hoping that the Transitional Stability Center will be an innovative way of being able to make a difference in the lives of people who are only going through the emergency department to have their needs met. The other service is in Chatham-Kent and Sarnia-Lambton, and it's a very homegrown solution to being able to engage primary care physicians to meet the needs of the more moderately mentally ill. Historically, there's been a silo between the seriously mentally ill and the moderately mentally ill, and those that could be accessing mental health services. So in order to break down those walls, we created the Rapid Assessment Intervention Treatment Team. And in that team model is available to primary care physicians. The team is composed of nurses and social workers and care assistants, as well as psychiatrists. We are looking at a turnaround time of less than 72 hours of response. We know that sometimes people with clinical depression, if we don't provide that support early on, the condition will worsen and they will end up in the emergency department. and we could have prevented it from the front end. So by breaking down those silos and to rebuild the relationship between the mental health providers and our primary care physician, we've introduced the rate model. So to date, we have been piloting it in 3 different locations in Chatham-Kent and several in Sarnia-Lambton, and we're hearing really good news and positive outcomes. It's a great way for the physicians to be able to have access to their own team, and the teams provide the mobile support. So the teams actually go to where the clients live. And that is really the best way to get a sense of what are the client's needs when you're within their environment. Oftentimes, if someone is so depressed or has had anxiety disorders, they're presenting quite differently in the physician's office. When they're in their own home environment, the team can not only provide them with provide the physician with a more accurate reflection of what their needs are and their struggles. We can work together in terms of making a better recommendation for treatment. So that is the Rapid Assessment Intervention Treatment Team. From a LHIN-wide perspective, we are engaging all of the chiefs of psychiatry in our Schedule I facilities as well as our tertiary hospitals. We're bringing them together with our psychiatrist lead, Dr. Tamison Dewey. We want to hear from the psychiatrists who actually know the most and the best practices, and we want to be able to take some of those hidden gems and to be able to leverage them LHIN-wide. So we are really looking forward to the kickoff of our psychiatry leadership table, which will be happening in November 2014. Similar to the mental health strategic plan, it's now time for us to shine a lens on the addiction population. Now we realize that 60% of the overall addiction and mental health population actually has concurrent disorders. We recognize that within the earlier 2012 mental health plan, and again we're recognizing it now with our new addiction strategic plan. The plan has officially kicked off in June, and because the summer months are so often slow and difficult to engage folks, we've been just now starting to ramp up. We have a survey for clients and families and providers, and it's posted on our LHIN website. We also have hard copies available. So our objective is to be able to dive deep into the addiction realm and to look at what are some of those needs. We know that the needs have changed radically in the last 10 to 15 years. With the changes from the ministry in terms of the OxyContin to OxyNeil, and the overall fact that Ontario has the highest utilization rate of opiates, we do need to make changes, and we need to look at our population differently. So it's not always those folks that are homeless that have an addiction issue. Quite often it's your neighbor, or it's even the white-collar worker. So we want to break down those stigma, and we want to learn more exactly where are the needs and what are some of the innovations that's actually happening. So we do have an addiction steering committee that is helping to guide the process. Initially, we had concluded that we thought that the addiction strategic plan would be ready for presentation to the public and the LHIN board in the early 2014, or December 2014. However, what has been happening is that we've been requested to have further engagements with various groups, including the anonymous groups of AA, NA, the harm reduction group, the methadone physicians, the various committees, as well as people in the general public, so the schools, the police, the courts, and it goes on and on. So because there's so many individuals that have a say in what the addictions, how it's impacted the populations and their families, we are going to take a step back, we're going to slow it down, and we're going to do it properly. So we're going to do a full-fledged engagement, which will slow down the release of our actual plan into the winter of 2015. But we do look forward to having additional engagement, and we have already had a kickoff with our physicians in Erie St. Clair LHIN, in Chatham, Windsor, and Sarnia, and we anticipate having a second round in case some of the physicians have missed that opportunity to verbalize their concerns and their needs. If you need to reach me and you'd like to discuss some of the promising practices that are moving forward or the addiction strategic plan, the fastest way to reach me is by email, and my email address is dawn, D-A-W-N, .Maziak, Maziak at LHIN, LHINS.on.ca.